unprecedented rise in the COVID cases, and there's a very high trend towards mortality in this particular peak. Right from the beginning of the pandemic, that is last year, there were multiple studies finding the optimal agents for the treatment, right from antivirals, the vaccines, the immunotherapies, and so was LDRT also. Although we do understand the amount of research for LDRT has not been to the tune we expected, but we still do have at least handful of phase 1 data and some ongoing phase 2 data. So today we want to hear it out from our national and international colleagues who have done this technique and what is their experience and what can be done further on to make this treatment more rewarding. So I will not waste much time. I will request Dr. Vinita Goyal, who is a very senior radiation oncologist in Delhi, my mentor, my teacher, I would say, to take off with the background of this entire talk, the introduction, and I would request Dr. Huku to please chair this particular session and give expert comments to the end of it. Ma'am, please take over.
So thank you, Kanika, and thank you everyone for joining in. We have a big agenda, and all of us are quite keen to understand the role of low-dose radiation therapy to lungs in the era of COVID-19 infection. So if I look at the, I hope I am audible. Yeah. So
okay.
Thank you. So I want to accept that I have no practical clinical experience of ever using low-dose radiation therapy for COVID pneumonia or any other pneumonia. I am also trying to learn this to our esteemed faculty. So if we look at the problem statement, we find that it's a huge problem. It is a ubiquitous problem world over. There are 164 million cumulative cases reported with 3.4 million deaths world over, which are already there because of the COVID infection. If you look at the situation in India, the situation in India is also quite grim. Till yesterday morning, we had 26 million cumulative cases with 2.9 lakh reported deaths. We don't know how many what is the actual number of deaths. So if we look at the percentage of COVID patients, we find that majority patients are going to be asymptomatic or will have a mild to moderate course of disease, which is easily recoverable. But it is the small proportion of patients who land up with severe disease are enough where the resources become least to manage them. They cause enough strain on the healthcare also. We also understand that the vulnerable patients are the patients who are elderly in the age group or patients who have multiple comorbidities. And the ARDS or acute respiratory distress is the leading cause of mortality. And it is reported that about 40 to 80% of the mortality in the patients who require mechanical ventilation. So basically, we want to avoid this situation of mechanical ventilation because of constraint of resources, as well as because we understand that the mortality is very high in this subgroup of patients. So today here in this meeting, may I request everyone to kindly mute themselves. So today in this meeting, we are trying to understand what is the role of low-dose radiation therapy and why we should be using it. So low-dose radiation therapy is the radiation which is a single fraction of 0.3 to 1.5 gray of radiation. And use of lung radiation therapy for pneumonias actually dates back to 1900s when it was used for treating pneumonias in the pre-antibiotic era. In fact, radiation was not only used for treating pneumonias, it was used for treating a lot of other inflammatory and infectious diseases like gas gangrene, carbuncle, sinusitis, arthritis, inner ear infections, etc. So this is a very nice compilation which was published in 2013, which is not very long back, where the authors looked at the role of radiation therapy in treating pneumonias and wondered if it still could be useful today. So these are the number of cases which the authors of this article have compiled, and they have reported about 700 patients who were treated for pneumonia, various kind of pneumonias, bacterial pneumonias, lobar, bronchopneumonias, with the pneumonias which were unresponsive to sulfa drugs, and interstitial atypical pneumonias which were effectively treated by using low-dose radiation therapy, leading to disease resolution based on clinical symptoms, biomarkers, and mortality incidence in this subgroup of patients. The authors also concluded that the mechanism by which the low-dose radiation therapy probably worked was the anti-inflammatory phenomena associated with radiation therapy. However, we do understand that these are case series, case reports. There was no control arm. It is probably a low level of evidence based on which probably in 21st century, it is not fair to start radiation therapy for COVID pneumonia in the present times. However, it still makes me wonder that what must be the role of radiation therapy in the 20th century, early 20th century. Probably it was like, we think of immunotherapy or monoclonal antibodies in the present era. For any problem, probably the investigators must be saying, okay, let's try radiation therapy. And that is how they must have embarked on the use of radiation therapy, even for the treatment of pneumonias. Even if we don't want to practice it today, I will say that radiation did work and saved several lives. And life is not only about going forwards and trying new therapies. Sometimes, to find solutions, one has to go backwards also, which is fine and fair. So how does this radiation therapy is likely to work for COVID pneumonias? Let's try and understand that. So whenever there is a SARS-CoV-19 infection, it leads to the activation of host immune system. Predominantly CD4 lymphocytes and T helper cells are activated. When these cells are activated, they lead to production of multiple pro-inflammatory cytokines and chemokines, which are listed here. And some of these cytokines are related to the severity of respiratory illness. These cytokines, in turn, activate the inflammatory cells and enter into the pulmonary circulation and induce what is called as cytokine storm. And they lead to a rapid and wide range of damage to pulmonary epithelium, alveolar cells, as well as other vital organs. So here, how radiation therapy in low dose works is that it acts as an anti-inflammatory action by causing suppression of IL-6, IL-4, IL-10, and other inflammatory markers. It has also been reported that when low dose radiation therapy is used in the dose of less than 1 to 1.5 grays, it creates anti-inflammatory action because of polarization of the M2 macrophages. And these are number of inflammatory markers, which some of which are increased or decreased. But in short, low dose radiation therapy has an anti-inflammatory and immunomodulatory role. But then there is also a lot of conflicting and contradicting data against these mechanisms of low dose radiation therapy also. So I would say that the waters are still muddy. The mechanism of action of radiation therapy is not absolutely clear. Now, while we have all been raving about the role of remdesivir, tocilizumab, steroids, etc., let's not forget to give credit to antipyretics also in the management of COVID-19 pneumonia. Here, I am trying to draw a simile between antipyretics and radiation therapy. Antipyretics, they work irrespective of the cause of infection. It does not eliminate the cause of fever, but it gives us symptomatic relief. Similarly, low-dose radiation therapy also works for all kinds of pneumonias, as we understand from the past experiences. It is not bactericidal or virucidal, but it has an anti-inflammatory action in the area where it is directed. For example, in this case, it is lung. So it can reduce the inflammation in the lung, which is caused by the cytokine storm, and reduce the oxygen requirement, which is certainly no less achievement if we can get it. And that too with a single dose of radiation therapy. But as a radiation oncologist, if I have to actually put it into practice, the use of low dose radiation therapy, I have a lot of concerns and worries. I want to understand the evidence. I want to understand who is the right patient, what is the right timing of radiation therapy, what is the right dose, what are the expected side effects, what is the likelihood of second malignancy, and there are a lot of logistic issues which also need to be sorted out. So let's look at the evidence first. So this was one of the first papers which came in favor of use of low dose lung radiation. This publication came from, I think, University of Atlanta. They initially treated 5 patients. This is by Professor Hess. They treated 5 patients with low dose radiation therapy. They gave a dose of 1 gray. And they found that within 24 hours of radiation therapy, 60% patients were weaned off from the supplemental oxygen to ambient air, and 80% patients exhibited radiographic improvement. Encouraged by their initial pilot study, they started with another rescue trial, which is a phase 1, phase 2 investigator-initiated single institution study, which again looked at the safety as well as efficacy of single fraction low-dose whole lung radiation therapy for patients who were hospitalized and patients who were dependent for oxygen after SARS-CoV pneumonia. In this study, they screened 51 patients, found 13 patients who were eligible, and finally 12 patients were enrolled. I want to emphasize that majority of these patients were elderly. The median age was 78 years. There were 10 patients who were selected and were considered eligible. All these 10 patients were oxygen dependent, but they were not intubated. All these patients were received low-dose radiation therapy and they were followed up for a minimum of 28 days or until discharge after doing the radiation therapy. They also identified a matched pair controls with equivalent disease severity and age, and they were also blindly selected. Evaluation of response was done as per the clinical findings based on the serum biomarkers and also radiographically. Patients who required more than 6 liters of oxygen per day, they were excluded, and all antiviral therapies were suspended 1 day prior and 3 days after the low-dose radiation therapy, and the control group received treatment as per the physician discretion. The radiation dose which they used in this study was 1.5 Gray single fraction to the bilateral whole lungs. It was delivered using APPA 2D radiation therapy technique with open fields. There was no CT simulation, no heterogeneity correction was also applied. So it was a very simplistic way of delivering radiation therapy. Now, when they looked at their clinical outcomes, they found that the median time to clinical recovery was 3 days in the experimental arm compared to 12 days in the control arm. Similarly, they also found that the hospital discharge was 12 days, median hospital time to hospital discharge was 12 days in the arm receiving low-dose radiation therapy versus 20 days in the arm which was in the control group. They also found that the freedom from intubation was 90% in the arm receiving radiation therapy versus 60% in the control arm. And the average duration of intubation, if at all required, was only 1 day in the arm receiving radiation therapy versus 4.3 days in the control arm. Similarly, on radiographic assessment also, they found that at day 21, any radiographic improvement was seen in the 90% of the patients receiving LDRT as compared to 57% in the control arm. This is a photographic view of the same response, radiological response after LDRT. And they also found that the inflammatory biomarkers were also in alignment with the clinical and radiological response. So all in all, they found that majority patients benefited with this low dose of simplified APPA single dose of radiation therapy. The authors have also accepted that there are several limitations to this study. First of all, it is a non-randomized approach, which was done with an exploratory intent. There are small number of patients. There are different control treatments. There are different lab and imaging schedules between low-dose RT and control cohorts. However, they have still made a very brave conclusion that there was no significant acute toxicity. At least it is not doing any harm. Patients who had COVID-19 pneumonia with oxygen dependence, with imaging showing pneumonic consolidations and clinical decline, they all recovered to room air at a median time of 3 days and discharged at a median time of 12 days. And all markers, be it clinical, serological, or radiological, they all favored observation in the arm. They all favored improvement in the arm receiving low-dose radiation therapy. Now, apart from this major study, there is another study which has looked at the role of low-dose radiation therapy. However, this study has looked at the role of LDRT.
No, I just smoke one cigarette. Seriously.
Kindly mute yourself, please.
I was said to me.
Yes, low-dose radiation for severe COVID-19 pneumonia.
May I request everyone to kindly mute themselves. So this is another study. This is a randomized double-blind study which has looked at the role of low-dose radiation therapy for severe COVID pneumonias. So in this study, in the first study, they included patients who had moderate disease, the oxygen requirement of more than 6 liters was excluded. While in this study, they included patients who were admitted to ICU with mechanical ventilation. Experimental arm was given low-dose radiation therapy 1 Gray with APPA open fields and the control arm was given sham radiation therapy. And both the arms also got the standard of care medical management. The ICU staff was completely blinded to the treatment allocation arm, and total 22 patients were treated from November to December 2020. And the median age group of the patient was 75 years, and the median number of comorbidities was 5. So I would say that they selected the worst lot of patients, patients who were elderly, patients who had multiple comorbidities, patients who had severe COVID requiring mechanical ventilation were chosen. And in this study, they found there was no difference in the 15-day ventilator-free days or in the overall survival between the arm receiving low-dose radiation therapy versus control arm. So probably these studies emphasize that the selection of the right patient is very, very important, very, very crucial. Now we know that the answers to all the questions regarding the use of low-dose radiation therapy are far away from being answered, and there are several studies. There are at least 12 trials which are, which are enlisted in the clinical trial GOV, which are looking at the role of low-dose radiation therapy, and maybe we'll find the answers as the time passes. So as I was mentioning in the previous two studies, the timeline of offering of giving low dose radiation therapy is very important. If it is used as a last resort, when the patient is already into ARDS, when the patient is already having mechanical intubation, then this radiation therapy is unlikely to work. We have to prevent the inflammatory response early. So probably we have to identify and add radiation therapy in the early inflammatory phase rather than late. An optimal timeline still needs more validation with radiological, clinical, and serological biomarkers. I think the exact timeline is not yet clear to us. Now, when we talk of worries in using LDRT, as has been emphasized earlier also, there are no symptoms of acute radiation sickness, which is reported in the number of patients who've received this low dose of radiation therapy, but our major worry is the incidence of secondary cancers. There are several models which have looked at the incidence of secondary cancers after a very low dose of radiation therapy. If you look at the childhood cancer survivor, the cumulative incidence of second cancers is reported to be 7.9% at 30 years. But remember that all these patients had a much higher dose of radiation therapy as compared to the low dose radiation therapy, which is being This is another model which has looked at, if there is a 25 years old woman who's exposed to 1 gray of whole thorax radiation therapy, then it is found that according to this model that the risk of lung and breast cancer is expected to be 5.9 and 5.5%. And similarly for the esophageal cancer, it will be around 0.3%. This risk decreases as the age of radiation exposure advances. For example, if a woman at 25 years carries a 5.9% risk of getting a lung cancer, if the same radiation is given at the age of 65 years, then the risk is reduced to 4.6%. So probably it may be more wiser to use low dose radiation therapy in elderly patients, which is a more vulnerable group and more difficult to treat patients with anti-COVID regimes. We may not actually use it in younger patients, but we can certainly use it with more confidence in the elderly subgroup of patients. Apart from this, there are several logistic challenges also, and probably with our faculty in the meeting today who have already treated a lot of patients with COVID, with LDRT, we will be able to understand how to overcome these logistic challenges, because the same radiation therapy equipment is used for cancer treatment as well as for the treatment of COVID patients. So you need to properly sanitize the radiation facility, as well as there is a concern of risk of exposure to the healthcare worker also. So a lot of things have to be accounted for before embarking on this journey. So I will say there are more questions right now than available answers. COVID pneumonia is certainly more different than other pneumonias because there is a rapid progression. There is an exponential increase in the inflammatory markers. There is lack of available effective treatment options. And overall, I think radiation community right now is still divided into the possible use and advantage of low dose radiation therapy. The evidence is also a little sketchy, and we have to understand that if radiation therapy is given at wrong time, then it can sometimes be counterproductive also. So what I think is that we need meetings like this to discuss, understand, and share our experience. And within our own hospital also, we need what should be called as COVID boards. We as an oncologist are very used to having tumor boards, and probably now we need to have COVID boards where physicians, pulmonologists, oncologists, radiologists, etc., all of us can sit together. If not sit together, maybe discuss these cases on virtual platform using hospital information systems to identify the optimum timing and optimum therapy for all patients. So that's all from my side. May I now invite Dr. Huku. Dr. Huku is a senior radiation oncologist of Delhi. And Dr. Huku, kindly give your expert comments on this. Thank you.
Thank you, Vinita. I think you gave an overview of what was there and what is going to come. Now, as you said, the use of low-dose X-rays treat patients with pneumonia goes back to early 20th century. And at that time, we all know that, there were very few treatments available for pneumonia like COVID now, because antibiotics were not there. And low-dose kilovoltage X-rays reduced the mortality from 30 to 10%, which was very, very remarkable. The people who used to use these low kilovoltage X-rays did not have a parameter as to decide what dose, what area. So one of the authors used the doses which was used in carbuncle and other pyogenic diseases. Likewise, there was no explicit study on the mechanism of action, but anti-inflammatory effect, as you said, of low-dose radiation was supposed to be the principal mode of action. You also alluded to, this study where there were more than about 800 patients, 863 patients in 15 studies. And out of this, 717 were cured, a remarkable result. People at that time understood the importance of randomization. And one author tried to randomize patients into giving kilovoltage X-rays and not giving. But the effect of giving kilovoltage X-ray was so remarkable, the respiratory distress disappeared in a couple of days, that the department people told him against randomization. So randomization could not be done. With availability of effective antibiotics between 1950 and 1970s, these treatments were discontinued and later never picked up, and further exploration in this area gradually died. There is no report about this treatment since 1946 until its use in COVID patients, which was published last year in 2020. Because there are very few patients treated in last many years, there is no robust data on long-term risk of this treatment. This subject is being revisited again now when we have an advantage of better radiotherapy technology. Not that we were not using lung bath. When we were students, we were using lung bath for diseases like Ewing sarcoma, for lung metastasis, and it was very easy to give on a cobalt machine at that time. But now we have a very better radiotherapy technology where a megavoltage beam could easily ensure that 99% of the whole lung volume receives 90 to 120% dose. And our increased understanding of additional effects of low dose radiation other than anti-inflammatory effect are there. While a large scale up of low dose radiotherapy treatment would not be without obstacles on existing strain on radiotherapy resources, separating COVID patients from cancer patients. And if we look at, I'll give you an example of Delhi. About 70% of the COVID patients are admitted in COVID care centers where radiotherapy machine is not there. Now, if you want to give radiation to those patients, how will you transport them from that place to the place where you have a radiotherapy machine? But anyway, many obstacles can be overcome. In India, especially, there are a large number of patients in the rural areas, which we are witnessing. And where is the radiotherapy machine in the rural areas? But anyway, now these are obstacles. Clinical trials by responsible investigators are required, because if we succeed, low-dose radiotherapy will have a potential to reduce mortality and alleviate COVID-19 related strain on healthcare systems worldwide. That is my take, and let us hear to the people who have experience, and over to Kanika.
So thank you, sir, for a very crisp remark. And I think, as you rightly said, what we need is the correct trials done by responsible investigators. I think that is the crux. And then there are
If I can have a few comments with your permission.
Yeah, sure, Dr.
It's a very lucid presentation, introductory talk, Dr. Vinita. Congratulations. It was very good. And Dr. Huku, nice overview about this. And we all know that low dose radiation is an anti-inflammatory response. Typically, we have done intravascular coronary radiation. It's also typically it's an anti-inflammatory effect. And you all know about the keloid. That's also an anti-inflammatory effect. I understand that we have never done that for the pneumonia patients because we have plenty of other options.
Correct.
So positive about this, and we also want to start at Hyderabad. And the whatever trials that have been done in the past are all been positive, except one trial which actually taken the patients who are on ventilator. So that what you rightly said is what time, right time to think of intervention is most important thing in this. And to add to that, I think between 90 to 93 percentage of oxygen, that's the right time. Impending time that the patients are going to become sick, that's the right time to intervene. And the technology part, instead of the APPA, we are looking at the planning with volumetric arc, which is going to be faster and easier with an isocentric technique. So I would request you to look from that angle as well. APPA is, of course, known to established, but you can also look at the volumetric arc. Thank you, Vinita.
Thank you, Dr. Reddy, for your comments. Now, I think moving forward, I'll invite Dr. Purvish Paras.
Ma'am, a small request, a very odd request. I would request a few of you to join in from YouTube link because the faculty is unable to join. We've exceeded our capacity of 100. If some of you who are not actively participating and just watching, then please join in from YouTube link. Sorry, very, very odd request. I'm really sorry.
Okay.
That's a good problem to have. Yeah, people are interested.
Yeah.
I will go on YouTube.
As chairperson, we invite you and start the next session, please.
Thank you very much, Vinita. It is my pleasure to be
Give
here.
us the co-host permission. We are in Dr. Sasasriya Govindaraja ID for us to share the slideshare.
Thank you very much, Vinita. Dr. A.K. Anand is my co-chairperson, and it's a privilege to have him with us. All of us know.
No, come.
He is a senior radiation oncologist at Max Hospital and a very dear friend. Without wasting much time, let us go directly into the next presentation by Dr. D.N. Sharma. Again, a dear friend who's professor of radiation oncology at AIMS New Delhi. So, Dr. Sharma, we are eager to hear you. Over to you, sir.
Thank you, sir. Let me share the screen, sir.
Yes, of course.
Can you see the screen, sir?
Yeah, it has started. Please go ahead.
Okay, sir. Can I start, sir?
Perfect. Thank you.
Okay, sir. So, respect chairpersons, my fellow speakers, and the dear audience, good evening and good morning to, in fact, Dr. James and Priyanka in USA. So, it's my pleasure to be on this platform. Thank you, Dr. Vinita and Dr. Kanika, for giving me this opportunity to share my experience through this trial. Now, since Dr. Vinita has already introduced the topic very nicely, I'll just confine my talk to the trial which you have done at our institute. So I'll just take 15-16 minutes in this talk. Begin with the rationale for using the low dose radiation for COVID-19, although much has been said by Dr. Vinita, but just to summarize, we have the strong historical evidence supporting the use of low dose radiation for the viral pneumonia, and of course now we are facing this pandemic. Scientific basis, we have very scientific basis because nothing has worked. Can you hear? Am I audible, sir?
There's some disturbance, sir.
We can hear you clearly, but there is a disturbance from somebody else.
Okay, so you can request the person to mute himself or herself. Anyway, sir, let me just continue, sir. So nothing has worked so far for the treatment of COVID-19. We have tried remdesivir, we have tried plasma therapy, so many treatments we have tried, but nothing is established so far as a proven treatment for the COVID-19. So we have a basis based on the historical data. It poses a negligible risk of the secondary cancers and or the toxicity. We have already available infrastructure for giving the radiation, low dose radiation. We have expertise as well. We have hello, Dr. Vinita, can you hear me?
Please go ahead, Dr. Sharma. Please go ahead.
Okay, fine. Thank you, sir. But of course, the challenge is also the risk of exposure to the staff and the caregivers, the contaminants of the treatment units which are all being used for the cancer treatments, other cancer patients, and right patient selection, when to intervene, as has been already pointed out. If you treat sick patients, low dose RT is not going to work. If you choose certain patients who are having very mild risk of the mortality, then it is a waste. So you have to target the right patients who are likely to benefit from the low dose radiation treatment. A couple of advantages of using the low dose. It's a very short and quick treatment. You just like 20 minutes. You don't require any consumables for this kind of treatment, unlike the vaccine or the drug, which have a huge cost. We have already spent millions of dollars for developing vaccine. So we don't have to spend any cost. The resources are already existing in the country. So therefore, no budget required. And the no impact of the viral mutations on the radiation, because it doesn't, the mechanism is entirely different. As you've seen, now we have a different strain, so probably it may or may not. We have already existing radiation resources in this country, and the low dose radiation can prevent the ICU admissions, which is a huge benefit for a country like India, where there's a shortage of the ventilators, and they can minimize the deaths for the healthcare workers who can catch infection during the ICU care. As per the ARV data, we have about 900 old machines in this country, and even if we devote or dedicate 10% of these machines for the treatment of these COVID patients, we can treat 4,000 patients per day in this country. That is enough for an incidence of like 40 to 50,000 patients per day. Therefore, we have every resource and every facility available in this country, and 90% of machines can still be used for the cancer patients, so it's not going to affect the cancer treatment patient's treatment. So therefore, we have the basis that the resources are already existing. This is just to compare the dose received by the low dose RT which we give and I just compared in a table. X-ray spine we get about 0.2 centigrade, CT scan abdomen by 1 centigrade, PET-CT we get 2.5 centigrade, and like in my study we use 70 centigrade, with somebody use 50 centigrade, just like doing 20 PET scans, and it is much below the dose limit for the lung tolerance, So it is very safe treatment in my opinion, Anyway, just come to the trial. This trial was approved by our ethics committee. It's already registered in the clinicaltrials.gov. When you do a trial of this nature in this country, I'll just share my experience that what are the various hurdles and challenges one can encounter. There are three kinds of hurdles. One is the ethical approval, then the fear of infection among the radiation team or the radiation caregivers, and the patient recruitment. So the first hurdle, ethical approval, because most of the ethical members are from the medical background. They are not from the radiation background, So they are like thinking that, oh, you are treating infection by the radiation treatment. So their mindset is different, So many times you will have difficulty in getting the ethical approval. And in fact, in the beginning, I submitted the trial of 50 patients having the randomized controlled arms, But it was not true. And I had, in fact, got 18 questions from the ethics committee. And I had a great difficulty in answering those questions, but ultimately I satisfied them, and they approved for only a single arm pilot trial. And I was happy because I was thinking this is not going to go through. So, but in the end, they approved for a single pilot study, of 10 patients, The second is the fear of infection among the radiation team. We must understand we are not the COVID team members, Ours, radiation is a known COVID, area. And in which we have the team members like medical physicians who are not clinicians, and they do not have the familiarity and understanding of the COVID-19. We have RT technologists also who understand the treatment only for like cancer. Radiation is used for only cancer, and they have the fear of catching the infection. So it's not easy. Now 1 year down the line, it looks very easy, but just 1 year back, there was a utmost care. There was time when the ward was refused to deliver the food to the patients, And in fact, my own colleagues could not come forward and refuse to participate in this trial. So we understand there is a fear in doing this trial, but of course now things are different. Now it looks much more feasible. We are capable of handling these COVID patients even in our non-COVID areas. But anyway, this is just one hurdle one has to face. Patient recruiting is another hurdle. Because most of the public think that radiation causes cancers and treat cancers, and when we do not allow the patient attendance into the X-ray room or the CT scan room, they understand that radiation is a fearful treatment. The another something with the mortality is very low in COVID patients, just 2 to 3%. Last year it was like that. So they think that 98% patients, why should we give the radiation? And then multiple research projects. This is another hurdle which I faced at myself, because whosoever patient was fit in my trial, he or she was already in some other like remdesivir trial or the plasma trial or in some trials. An institute like us, which is capable of doing this kind of trial, has multiple projects going on. So you will have difficulty in competing with, including the patient. Anyway, these are our aims and objectives for this trial: to study the feasibility of the low dose radiation for the COVID-19 pneumonia, and the second objective was to evaluate the clinical efficacy of the low dose rate in COVID-19 pneumonia, and the sample size 10%, as I said. Eligibility criteria: we had confirmed cases of COVID-19 confirmed by RT-PCR, and we included patients who had moderate to severe respiration as per the new score. I'll just come to that what is the new score, and patient consent, of course. The patients requiring ventilator support and unstable hemodynamics were excluded, in fact. So any patient who is on ventilator or in ICU was excluded from this trial, and any patient who had like low BP or unstable hemodynamics were excluded from this trial. New score is actually, it's a national RB warning score. This is used by people who practice in ICU and the medical setup. There are many scores which are used for predicting the outcome of any serious illness. Scores like SOFA and STARS. News is also one of them. Now the beauty of this scoring system is that this is based on only the clinical parameters, which suited us. There was a time when people were not ready to take samples for these patients. So we didn't have any imaging or the blood innocent criteria for our trial. So that's why this trial, this new score suited us. So it consists of the respiratory rate, heart rate, fever, blood pressure, oxygen saturation, level of consciousness. So these are all clinical parameters and easy to study. And these are having each parameter has a scoring. So any patient having a score of 5 to 7 was included in this trial. This is just the scoring system. I will not go into details, but it's all the clinical parameters. So according to this score, any patient having the risk of a score of 1 to 5 is a mild risk, a score of 5 to 6 is a moderate risk, which has a 15% critical event or the morbidity, and any patient having use score of 7 is labeled as a severe disease. These patients have 24% critical event rate, which includes mortality and the isolation. We in fact took the isolation as an endpoint, because we think that if patient goes to ICU, it means that low dose radiation has not worked. So we targeted patients having the moderate risk and severe risk disease, which we thought is the right kind of patient population which are going to benefit from the low dose radiation. This was the workflow that we had to arrange the transport of the patient from the ward to the where they were admitted to the machine. We had to secure the lift, we had to secure the corridor, and it was not a simple task. A lot of logistics are involved in this, and it's not, as Dr. Hooper has already pointed out, it's not easy to transport these patients and to keep the isolated place, because these are crowded place in India. Every hospital is crowded. It's not difficult to isolate and secure these areas. Then the treatment immunization, because patient is on oxygen, and patient may not be in a position to understand the kind of instruction we give. It is not that easy to deliver the treatment. But anyway, this was our workflow. Parameters we assessed for the response were: one was symptomatic improvement, because we feel that the clinical improvement has to be based on symptomatic improvement, or the deterioration in the baseline new score, which is purely a clinical score. And we studied on day 3, day 7, and day 14. And we think that if the patient improves the details between day 14, it's the right kind of assessment. And then length of assessment, length of hospital stay, because we think that if this low dose can curtail the hospital stay, that is also good for countries like India, where there's huge shortage of the beds and all that. Number of ICU admissions or deaths is also taken as a endpoint. The dose prescribed by us was 70 centigrade in a single at the midpoint or at the middle of the APPA separation. And we use linear accelerator in all patients. We're using 600 photons, and we use only just 2 open fields APPA. We do not use any CT-based imaging planning, or we did not use any, CDCRT or IMRT, because we think that doing a CT scan in this patient will take extra time. They are on oxygen and some of them are not really well. So, and plus the exposure to the CT scan staff and then the planning staff unnecessary, So we thought that we can avoid all that, and we can just simply use two pills with a dose like 70 seconds with a very mild, So we thought APP is a very safe treatment in this case. We prefer treatment on the weekends. Typically, we did treatments on Friday afternoon and then Saturday like morning, And we use non-touch technology. We prefer not to touch these patients as far as possible. We use some of the technology like mobile and WhatsApp in talking to these patients. And we had some pre-calculated, for the field size of 20, 20, 25, 25, 30, 30, so that even before the patient was taken up, we already calculated for a separation like that, And whichever was nearer to that patient separation on the field size, we used that, So it helped us in saving the time, The first patient, of course, anyone who is the leader of the trial has to take the lead. And in fact, I was the first one to don for the first patient who was treated first. So this is actually Dr. Supriyo, who is a faculty at MCI. So we both changed, in fact, and that gave a boost to the entire team, and the technologians, they were not very scared while entering the treatment machine with us, So this is one message I want to give, that, if you are the leader in your trial, you have to take the lead and at every front, Anyway, this was the clinical profile of all our patients. I will not go into details, but I'll just tell you the summary of this, clinical profile. Our patients were a little younger than the patients who were taken in the other trials like Emerald trial and the Bexel trial. The median age was around 50, 51. The other reason, in India, the longevity is lower than the others. So our longevity is a decade earlier or 15 years earlier than the Western. So just like 16, 69 years of the average age in this country. So we cannot have the same kind of age population in our Indian trials, But anyway, ours was 51. All patients were male patients. None our patients, in fact, most of the patients did not have the comorbidities, so they were a bit settled than the other trials, Only 3 patients had the comorbid like hypertension and diabetes. The respiratory was about 20. Saturation was mostly like 90, 93, 95. None of the patients had saturation below 90%. We thought that any patient going saturation below that, probably may not get the, But of course, all patients were on oxygen therapy. Temperature was settled because they were getting the crocin and IV paracetamol, so it was mostly under control. BP was also controlled. So hemodynamic, they were stable patients. Heart rate was also fine. New score was, if you can see on the screen, mostly it was like 6 or 7. 5% had a score of 6 or 7, and 50% had the score of about 5, So these are the response rates. You can see the hospital stay was about less than 2 weeks. Interval between the admission and the low-dose RT treatment actual was just like 2 or 3 days. Baseline score was, as I said, I just said 6 or 7. On day 3, the score was, the better. And maybe in the next picture, I can show you the, this is just a graph showing you the response at speed of the recovery. By day 3, most patients had the, recovered. Their new score was better. And by day 7, all patients except 2 patients had the, the touch the baseline score. And 1 patient had recovered by day 14, and 1 patient died. He was restricted to the ICU, intubated on day 3 of the low-dose after low-dose radiation, and he ultimately died on day 7. So we had 1 death, and the rest 9 patients recovered fully and were discharged from the hospital. This is just to show you the comparison of our trial with the other trials. The Emerald trial had 10 patients. The Iran trial had 10 patients. Madrid, Spain trial had 9 patients. Brazil, Switzerland, which is a negative trial. I won't say negative, but it's a trial not showing the LDRT benefit. So 11 patients. 11 patients, I said, in the RT arm, They had 2 arms. One arm was the control arm, which was having 11 patients. So they had 22 patients in total, but the LDRT was only 11 patients, Our study has 10 patients. So most trials so far has used LDRT in about 9 to 11 patients. Median age, as you can see, Emerald trial in the beginning 5% of 70, 90, but now it is like 70, as Dr. Venus has told. Iran trial 72 years, Madrid 66 years, Brazil 75 years. They were a bit elderly than the other trial, and ours was just 51. Number of patients in each trial having comorbidities was more or less 80 to 90%. We had about 30% comorbidity in our. So our patients, I would say, bit settled and bit better than other baseline, better than other trials. Interval again, most trials gave the LDRT within 2 to 5 days of the hospitalization. If you see the dose prescribed, the Emory trial has used 1.5 gray, and Iran trial has just used 0.5 gray. Madrid 1 gray, Brazil 1 gray, and we use 0.7 gray. We use 7 gray. The logic which we had thought that if you see the historical data, they had the median dose of 0.5 gray, but that was the unfiltered dose. That time there was no concept of the lung correction factor. So if you apply the lung correction factor, that 0.5 gray has actually become 0.7 gray. So that's why we use 0.7 gray. Emory trial, they have used in fact 2 APPA fields. Tehran 2 APPA fields. Madrid, Spain had used 3 DCRT. Brazil trial, if you see the trial carefully, they use only single field. They've treated the patients on the couch itself since they were ICU patients, so they use only 1 field. So remember, they have not used 2 fields; they use only 1 field. And our trial, of course, we have 2 APPA fields. Recovery rate, Emory 90%. Tehran 60%. I think they had the worst sort of results, although they had multiple comorbidities. Madrid, Spain had 78% recovery rate. Brazil, Switzerland had shown 64% in both the arms, more or less, and they have shown that it doesn't benefit with the control arm. Ours, of course, was a single pilot study, so we had 1 patient died, 90% survived. So our response clinical is 90%. So we can say that our is at par with the Emory trial, and it is one of the best so far, although the limitation was there. But if you see the number of patients, every trial is more or less 10%. So our recovery was 90%. No toxicity was seen in our trial. All patients were fine. We could not see any toxicity. So just to conclude, I would say that low dose radiation to both lungs for COVID-19 pneumonia is feasible in our study. See, our first parametric study was the feasibility. None of our staff members got infected during the while treating these patients, and we could, complete the trial within 3 to 4 months. Although it looked difficult at one point of time, but we could complete the 10 patients trial in 3 to 4 months time. It's a small sample, I agree, but that's the limitation of every trial so far which has been published. Rationale is 90%. It suggests clinical efficacy and must be tried in a large randomized controlled trial. Thank you very much.
Thank you very much, Dr. D.N. Sharma.
Just give me 1 minute concept. I was just showing the picture. He's our director, and he was very supportive. In fact, when I went to him in the beginning with a PPT presentation showing, sir, I have a novel treatment to offer, and he was just in 2 minutes time. He said it's an innovative treatment. You must try it. So he was very supportive. And I would say this trial would not have been possible without the support of our director. So I'm all thankful to sir. Thank you very much. Sir.
Perfect. Thank you. We now move on to the next speaker, Dr. Patanjali Singh, who is head of radiation oncology at AIIMS Patna. Earlier, she was at RCH in Patna and also a dear friend. My sincere request, please stick to the time. We are already way behind the schedule. Thank you very much, Patanjali. Please go ahead.
So thank you very much, respected sir, and I'm grateful for Dr. Vinita Goyal to for inviting me and asking me to share my experience with the preliminary data for the low dose radiation that we have. I'm not unable to share my screen. I think Dr. D.N. Sharma has to. So yes, sir. So I'll just share my screen first. So a very good evening, everybody. As the task was given to basically showcase our experience, real-time experience and institutional protocol for the low-dose radiation therapy that is being done at our center, it is prudent here to let you all know that our center was a dedicated COVID hospital starting right from June 2020 to January 2021. Yet we did start our oncology services for the normal crowd from October 2020. So we were doing both from October 2020 itself. So our department of radiation oncology actually we started this clinical trial of study of impact of adding low-dose pulmonary radiotherapy to moderate COVID-19 pneumonia patients. I am the PI, and we have very, very learned team members, which include pulmonologists, which include critical care team, as well as the medical team itself. First of all, of course, we did the departmental research committee approval, and then we did the institute research committee approval, whereafter we got the ethics approval on 30th of 11th, 2020 for our trial. And we also were able to get the intramural funding for this trial, which was actually very, very encouraging. So the objectives of the study was to see the low dose radiation. The primary objective was to evaluate change from moderate to severe grade of disease in both the groups with NEWS2. So we had two groups basically. One was a control group, and one was the radiation group. And NEWS2 was the primary objective of our study, to evaluate the change in the NEWS2 scoring. Time frame was day 1, day 3, day 7, and day 14. The secondary objectives were many. To name them, physiological NaO2 and FiO2. The laboratory testings which would be done were WBC, platelet, ESR, D-dimer, LDH, ferritin, IL-6, and CRP, the inflammatory markers. CT thorax would have been done on follow-up of day 7 and 26, 28 as well from the baseline, that is day 1. Radiation-induced acute and late lung toxicity monitored on the basis of CTCA criteria 5 scale, and conversion of non-invasive into incubation in the hospital. So these were the secondary objectives. So with these objectives in mind, we had an inclusion criteria which included age group from 18 years, more than equal to 18 years to 70 years. Patients were confirmed, had confirmed diagnosis of SARS-CoV-2 infection, and they were all having RT-PCR positive reports. Patients were having moderate disease with SpO2 less than 94 on room air and respiratory rate of more than 20 breaths per minute on room air. And the crux of the idea was that we would take these patients with less than 10 days of symptom onset to avoid the cytokine storm. And suggested picture maybe would have been also be used as one of the inclusion criteria if we would have seen chest X-ray or CT scan as one of the patient having pneumonia. The patient should be having the ability to understand and sign the informed consent, ability to acquire and maintain the setup necessary for therapy treatment. And if the patient was young and the patient was childbearing age, then of course for the females we would advocate a negative pregnancy test. The exclusion was those patients with severe disease, patients undergoing invasive mechanical ventilation or autoimmune systemic diseases, those patients who were hemodynamically unstable patients, and patients with a positive pregnancy test, and impossibility to maintain the setup necessary in the radiation department treatment. So methodology, it was a prospective, monocentric, double-arm, interventional, randomized, non-pharmacologically exploratory study, and the sample size was 22 patients, 11 patients in each of the arms. As you can see from this flowchart, first of all, counseling was done, which was very, very important, and it was difficult as well because many of the patients, even those patients that we actually first of all saw that they were included in the inclusion criteria and they could come and they were willing to come after counseling, many of them dropped down. Consent was there after taken from not just the patient but also the attendant. Then they were randomized into two arms, arm A and arm B. The arm A, the patient would come to the RT department, CT simulator room, would CT scan would be taken on day 1, day 7, and day 14. Day 28 of treatment, and the blood parameters would be also taken on day 1, 3, 7, 14, 28, and also 6 months from the treatment. And in the arm B, only CT scans would be taken on day 1, 7, and day 28, and 6 months after therapy. With the therapy that was already going on in the wards, of course, the institutional COVID treatment guidelines were followed in both the arms as per the guidelines itself. So the arm. So you can see here that as Dr. D.N. Sharma had highlighted, that we had to keep the radiation oncology wing empty at the time when we took the patients for treatment. And we were doing simulation, and we were also putting masks that is the thermoplastic cast, so that we could maybe plan our patients with VMAT or whatever would be feasible. So the first patient, we did do a planning with VMAT as well. So we actually had a protocol of putting thermoplastic mask on all the patients, and you can see basically the precautions that are being taken. The patient also comes in a PEP from the wards, and of course this video is not playing, so I won't be able to show you exactly, but I would like to go ahead. After CT simulation was done, I'm not able to move my slide actually. Yes, so after CT simulation was done, sorry, after randomization and CT simulation was done, then the patient was treated after dosimetric analysis, and you can see that all the patients were monitored very well with a monitor in situ in the treatment machine room, and they were taken back to the inpatient department where they were kept for treatment, with of course under supervision of a doctor, and of course also under monitoring, so that they were very safe and in good hands while being transported back. So these are certain, I would like to share certain videos, but I'm not sure whether they will play. So maybe I can, I will just have to go ahead, and I'll have to go ahead with the pictures that we have taken. These are two, you can see the results. Day 1 of treatment, the CT scan, and the day 7 of treatment of the same patient, which shows mild resolution in this area. Again, day 1 of treatment for another patient, and you can see the mild resolution that has occurred in this area on day 7 of the CT scans. So these, you can just see over here that first of all, I would like to disclose that these are not my, of course, we're into the trial, so we have not analyzed our cases, but the preliminary results can show you that a person who had oxygen flow of 8 liters within the 3rd day dropped down to 4 liters, and then on 7th day did not require oxygen itself. And similarly, the IL-6 levels maybe were decreasing, so were the CRP levels. So this we have enumerated for all our patients. We don't have the results ready as yet. We are into 8 patients treated, and 6 patients treated, and 3 patients on the control arm treated already. And we are getting very, very promising results. Of course, News2 score is the main criteria we have to see in the primary objective. And we have, you can see the first 4 patients that we analyzed, and the News2 score was done for them. And you can see the drop in the News2 score on day 7. The above 4 patients, out of them, 2 of them, the number 1 and number 3, they were discharged on the 7th day itself. So, I would like to share that, yes, as Dr. D.N. Sharma sir has said, that it is very, very difficult. And as Dr. Vinita Goel ma'am has also said, that there are many questions that are still unanswered, and we are facing trouble.
I think we have to little bit hurry up. We are getting late.
So these are the challenges that we are facing: taking consent from the patient and attendants, limited manpower, sterilizing the CT simulation and LINAC machines after treatment, minimizing contact with healthcare personnel and other patients. But we are able to do it, and we are following the evening treatment for these patients, so that the machine can be taken for the other patients on time. So thanking everybody, and hopefully I'll be finishing soon with of course the details of the trials ready to be disseminated otherwise. And this is just one picture showing that there are many other problems, like glaring of the lights of CT sim room. Mobile phones also had to be wrapped up in transparent plastic sheets, so it was difficult to even see and visualize. And this is my team. Thank you so very much.
Thank you very much.
Thank you.
Yes, Anil, please go ahead.
Yeah. Thank you, Dr. Pitanjali. Very nice to see what you have done in Patna. Very heartening to see another radiation oncology center doing a pioneer, I would say. It's a pioneer work. Very few examples available. So thank you very much. So now I will invite Dr. Sasipriya and Dr. Govind Rajan from Trichy. I think they are also going to show their real-time experience with COVID-19 patients. So I didn't imagine in India so many people were doing this this kind of trial. We thought only AIMS New Delhi was doing. So please start.
Yeah. Good evening, everyone. Am I audible, sir?
Yes, sir.
Yeah. Okay.
Yes, sir.
Yeah. We thank the organizers for giving this opportunity. I'm going to talk about the ongoing trial, WIN-COVID trial, using LDRT for COVID-19 pneumonia. This is a randomized parallel group active control trial, which is being conducted in Harshamitra Cancer Center, Trichy, Tamil Nadu. Actually, we got the CTRI registration for recruitment from October 2020 itself. But in the initial phase, we couldn't get much cases because by the time we started recruiting cases, the first wave had gone down. And so we didn't get much cases for recruitment. But after the second wave started, we have seen a lot of changes happening. So there is actually a desperate need now because we see the number of deaths have increased. There's tremendous oxygen shortage and thronging of people for the remdesivir. Then hospital beds are full, and latest we are facing this black fungus also. So now, but still on the treatment side also, a lot of changes have happened because we see the standard drugs are failed, and there is now a desperate need for looking into newer modalities. So compared to the last time, the first wave, now after the second wave has started, we have seen many young radiation oncologists and the COVID treating physicians are showing a lot of interest in LDRT. We are getting a lot of calls inquiring about the trial. So that is the scenario currently. So I'm just going to divide my speech into three parts. In the first part, I'll explain what got us into this trial. And second, what we are doing and how we are doing it. And finally, what we have experienced so far and what we have to say for the younger radiation oncologists and the COVID treating physicians. So I'll start with what brought us into the trial. Somewhere in March, end of March or beginning of April, we got this WhatsApp message where it was addressed to Dr. Stephen by Dr. Jerry Cutler. And Dr. James Welsh was introduced as the principal investigator. So I'm excited to have Dr. James Welsh in this webinar today. And at that time, this was the letter which brought us interest into the field of LDRT in COVID pneumonia. And then we started having a lot of literature search. We had a lot of papers which were for LDRT in COVID and a lot of papers against LDRT in COVID. And though there were so many papers, notable among them was the paper by Calabrese, which was for radiation. After a single dose of 0.3 to 0.5 gray to the patients in COVID pneumonia, the cytokine storm abated so quickly. There was a rapid amelioration of the systemic inflammatory cascade. That was the observation in Calabrese paper. And then on the other side, we also have this notable paper by Cisco Salama, which most of the people quote. But this was raising concerns on two aspects: the radiogenic cancer and the increased incidence of circulatory disease. So we were initially in a dilemma, whether to start this LDRT trial in COVID or go by Cisco Salama and avoid it. So it was then these two concepts that actually convinced us. There is the hormetic response concept proposed by Calabrese, and the concerns raised by Cisco Salama regarding radiogenic cancer and the increased incidence of vascular events was based on a linear threshold model, whereas Calabrese proposed a non-linear threshold model. Thereby, so when we go to the lower side for the low-dose radiotherapy, the excess absolute risk of developing a radiogenic cancer as estimated by the Preston formula was very insignificant. It was only 0.4. Then we also went through a lot of literature which were describing about the malignancy after radiotherapy. So having read all this, we were quite convinced that the incidence of the risk of developing radiation-induced cancer is much low when compared to the pandemic situation and the real need. The second concern which was raised by most of the treating physicians was the selective pressure on the virus, which can lead to newer mutations, whether this LDRT will create a lot of mutations. Here again, we had some literature search and we got two good papers on that. And first of all, LDRT, the mechanism of action itself is not antiviral. So it is on the immune system. So there is no question of selective pressure on the virus. If at all it has to be of concern, and it should be of concern in the antiviral drugs like remdesivir. So that was another paper. And then having convinced with the safety of LDRT, then we had this question of whether it really works. And that is when we went through the historical paper. This Powell study, it was very, very interesting because in 1930s, before the advent of antibiotic itself, the rate was so excellent. They were getting so much of good response with radiotherapy for COVID, for pneumonia. But the most interesting lines which we read and which we are experiencing now is these lines I just read out. It is important to establish that Powell had intended to employ radiation therapy in alternative cases of pneumonia to evaluate patient responses. However, Powell stated that his staff would not permit this alternating process. So he was trying to have a control arm, but his staff would not allow him to have the control arm because the patients receiving the X-ray treatment were relieved of the respiratory and circulatory distress within 0.5 to 3 hours. This is exactly what we are experiencing now because we are in the middle of the study now. We have got a lot of patients recruited already. And in all these cases, we are able to see a visible improvement in the oxygen saturation and the patient sense of well-being. Those patients who had distress, respiratory distress, they feel so comfortable within few hours after the LDRT. And this history repeats itself. We really got a call from our center's head nurse who refused us to have a control. So she was telling us to recruit all the patients because the patients were improving so dramatically. So this was the radiological response in Powell, and we are also seeing similar responses now in our study too. And regarding the dosage, then again we had to go to the Calabrese study. Then we were looking at the pathophysiology, and we all know the mechanism of action. So having got convinced with the mechanism of action, how it works, then we actually got into the study. And then the next question was regarding the fixing of the dose. Then again, we went back to the Calabrese study where they recommended 0.5 gray because we saw these data that with a lower dose of less than 1 gray, the pro-inflammatory markers reduce, the anti-inflammatory markers increase. That is what we want. Whereas on the contrary, if it goes above 1 gray, then the chances of pro-inflammatory markers increasing is higher. So we opted for a less than 1 gray dose, and we went by the literature evidence and went for a 0.5 gray dose. So that's what we are using now. And then we had a data search on all the existing ongoing trials. And we also had an opportunity to discuss with Dr. D.N. Sharma, that was in October 2020. We also had a discussion with Dr. Khan of Emory University. And having all these eminent people's preliminary experience, then we started this trial. So in our center, how we are exactly delivering the radiotherapy, that I'll hand over to my wife, my co-investigator. She's Dr. Sasipriya, radiation oncologist.
Good evening to all. I'm going to talk about the conventional low-dose radiotherapy planning for COVID-19 patients in our institute, Rationale Oncology Private Limited. It is a conventional method. We use variant unique performance linear accelerator in single energy SSD 100 centimeter. Patient is positioned on the Lina couch and mid-chest wall is aligned with room lasers. Patient position is supine. Head position is straight. Neck slightly extended with neck rest to be arm position, both hands above the head. No immobilization. Our target volume is to cover entire bilateral lungs. Field borders superiorly just above the suprasternal notch, inferiorly 2 cm below the xiphisternum, laterally 2 cm medial to anterior axillary fold on either side. Patient separation measured with vertical couch movement with the help of SST indicator. Half of separation is considered as prescription depth. Our field size range from 23 to 30 into 30 for covering entire bilateral lungs. Coming to patient setup verification, SSD is verified. Patient setup verified.
Okay.
Electronic portal image device. Fields is also confirmed whether it is covering entire bilateral lungs. Treatment portals. We are giving in ABPA field 0.25 in AP and 0.25 in PA for total dose of 0.5 gray. At dose rate of 100 monitor unit per minute delivered based on field size and prescription depth is usually ranging from 27 to 31 monitor unit. Beam on time 20 to 25 seconds per field. Total treatment time 7 to 10 minutes only, including patient positioning, repeat verification, beam on time, shifting patient out of the renacrum. This is the radiation technique that we are following in our institute. Now I hand over the principal investigator of our study to share the preliminary experience.
Okay. So we have covered why we got into the trial and how we are doing it. So now this is our preliminary experience. This is a CTRI registered trial in October, and it was open for recruitment since November 2020. And the initial phases, we didn't get much cases. Now after the second wave, we have recruited so far 39 cases. As on 25, we have recruited 39 cases. So initially we had designed it like this, all RT-PCR cases of age group from 18 to 90.
I think you have to conclude now. We are getting late.
Okay, sir. Okay. So I'll just jump to the conclusion. So from the pilot phase of 10 cases to assess the acute toxicity, we have now moved on to the comparative phase where we are recruiting 1:2 recruitment ratio. We are aiming for a 17 case in the control arm and 34 in the experimental arm. And we are following up with the SpO2, PaO2 based on the ABG, and then biochemical parameters, CRP, ferritin, interleukin 6, D-dimer, and these are taken at the interval of day 1, 4, 17, like that. CT chest is done at baseline and then on day 14. Chest X-ray is done at baseline and then on 3rd and 7th days. So our preliminary experience shows LDRT is safe because none of the patients had any acute toxicities. And significant finding has evidence in AIIMS Patna study also. There was a significant dramatic improvement in the oxygen demand, particularly in this time, in this second wave, where we are experiencing an acute oxygen shortage all over the country. This has a real significant effect because all our patients return to.
Sir, you have 1 minute now to conclude. 1 minute left.
Yeah, and based on our experience, we had poor results in patients with NIV or who are on very high oxygen flow and CT severity score higher, and patients who present more than 2 weeks. And of course, we had some, this is the disinfection protocol. And with this, I'll conclude because we had some challenges with the linear accelerator. Now, what we have come up with is a portable radiotherapy radiation machine. So this, we have named it as COVID-X, and we have got the AERB type approval also. This is yet to be commissioned, and we are planning for another trial that has been registered with CTRI that is exclusively using the mobile, because we have the advantage of being portable. It goes to the bedside, avoids the shifting. All these disadvantages that we face in the LINAC can be overcome with these portable machines. So that is our area, but this is also not a very novel concept. In the Calabrese paper itself, they were using the KV range machines only. So, and in the Calabrese paper, this is my last slide. So they were actually suggesting us to use X-ray machines, portable X-ray machines, and that was not available anywhere in India. That is why we have devised our own machine, but it is yet to be seen. But here, very importantly, these lines are very pertinent now. Unlike vaccines and pharmacological treatments that are dependent on stock production and distribution from manufacturers, right now we are facing vaccine shortage, we are facing remdesivir shortage, but unlike that, these machines there will be only one-time manufacturing, and that can be used for a very long time. I think it is high time. What I want to tell in my concluding remarks is, this is high time that more and more studies are taken up for exploring the role of LDRT. And once we are established, we can also go into the possibility of developing portable devices so that at least we are prepared for the future. Thank you very much.
Thank you very much. Wonderful. We move on to the next speaker. We have Dr. Welch, who's from USA, and may I hand over to you, sir, for the next session, please.
Yes, good
Dr.
morning.
Welch.
Thank you. Let me see if I can share my screen here. Okay. Can you see my presentation?
Yes.
Okay. So
please go ahead.
Okay, so I will not rehash all of the topics that have already been discussed. What I will talk about today is the clinical trial that we have drafted through the United States Department of Veterans Affairs, so-called study 2021 low-dose radiation for pneumonitis of COVID-19. I will not go through the details because that has already been rehashed extensively. The goal is to avoid the cytokine storm, not to try to reverse it, because radiation will probably not be effective at reversing once you've gotten to that point. The historical rationale for this has been reviewed by Ed Calabrese and Gaurav Dewan. People have spoken extensively about their work, which is critically important. Our study was switched from a phase 1 to a phase 2 type of study that was aimed to treat patients who would need admission to the hospital and need supplemental O2, but not requiring admission to the ICU. The study is randomization of 2 arms, 0.5 gray versus 1 gray. The objective of the study is to reduce by 20% the rate at which patients will progress to need for ICU management within 14 days or require invasive mechanical ventilation or death. Secondary objectives include measurements of safety and relative efficacy of the 2 different dose arms regarding the number of patients who require intubation, the length of the hospital stay in terms of days, and the all-cause mortality during the 30-day follow-up period. Laboratory correlates, of course, would be followed. The radiation is intended to be a single exposure with minimum movement of the patient, of course, meaning the patient would be seen in the emergency department. If they were requiring oxygen and deemed to require hospital admission, but not ICU management, they would be transported down to the radiotherapy department for their treatment. The patients would then be followed for 30 days and appropriate imaging studies would be implemented. I will not go through the rationale of why this treatment is appropriate. This has all been reviewed by others. A critical point is to not wait until the disease is too advanced, because there is a window of opportunity temporarily before this treatment will no longer work. We believe that 0.5 gray might be the appropriate dose. The range could be 0.3 to 0.7. I am skeptical that doses as high as 1.5 are appropriate. As far as the radiation therapy details, again, this is for patients who oxygen, but do not require ICU setting management. The treatment would be 0.5 or 0.7. Sorry, is there a question?
Sorry, that was some bad
Sorry.
background.
The 0.5 or 1.0, but I believe 0.3 or 0.7 could be more appropriate. The technique would be APPA, SAD of 100 centimeters, 100 monitor units per minute. Again, patients will be minimized in terms of their mobilization, going directly from the emergency department to the radiation department, and then from there to the floor. It's a single exposure. We may use CT if it is available, but we would not plan to take the patient into the radiology department for a specific treatment planning CT. It should take 20 minutes or less to actually generate the plan, regardless of whether the CT is available or not. We believe there is a temporal window of opportunity, and the treatment must be administered before the patient is so ill that they require mechanical ventilation. For those who are on the ventilator, we do not believe this is going to work based on several of our studies, and we provided a comment in last week's Red Journal. As far as practical issues, this is my last slide. We like to have these patients as the last patient of the day, if possible, but as I said, they would be going right from the emergency room to our department, so it could be any time. The room will have to be terminally cleaned afterwards. The patient will be escorted through the hospital to avoid contamination. That means use of a dedicated elevator, special corridors, and cordoning off of the radiotherapy segment after treatment. And those are the practical issues. Unfortunately, I do not have clinical data to present here today, but I appreciate the chance to be with you today.
Thank you very much, Dr. Walsh. That was really nice. And I'm sure that we will get back to you with questions on how you handle the cleaning and so on and so forth. Can we move to the next speaker, Dr. Priyanka Kapoor, also from Virginia Commonwealth University, Richmond. Ma'am, over to you.
All right. Hello, everyone. So I am going to talk about the treatment planning aspects for the LDR treatment. What did you do? Can you all see my screen?
Yes, we can see. Nidhi, can you mute yourself? This is not Nidhi Patni. Some other Nidhi, please.
All right. So since a lot of speakers have already talked about the historical perspective, so I'm going to skip that slide and straight away move to the safety considerations that need to be taken care of before we think about treating these COVID patients into our LINAC walls. So one of the important factor that we always want to ensure is the safety of the healthcare personnel and the other hospital staff that are involved with the treatment of these patients. Also, we want to make sure that our cancer patients that we are treating on these linear accelerators remain safe. So the LINAC vault must be evaluated and seen whether it's a negative pressure room or not. So a negative pressure room is usually a room.
Your slides are not moving.
My slides are not moving.
Yeah.
Okay, let me share them one more time.
Thank you.
Screen.
Can you see them now?
Perfect.
Okay. So a negative pressure room is basically a room where the air pressure inside the room is lower than the air pressure outside the room. So the contagious particle in the air do not move outside the room when a door is being opened. So the other important aspect is that there need to be some time allotted at the end of the day, which is the most appropriate time to treat these patients. And a thorough cleaning must be done after these patients are treated. So probably coordination must be maintained with the infectious control team of the hospital to disinfect the room after these patients are treated. And also several timeout procedures need to be designed in order to make sure that no catastrophic errors happen while this treatment takes place. I can't move. All right, so here are some of the consensus recommendations which are proposed in several clinical trials that are being run in United States. So usually the intention is to keep these treatments very simple and straightforward. A 30-minute time is usually allotted for such treatment, and it needs to be quick and easy for our staff which is involved in the treatment, and also for the patient as well, because they are already have difficulty breathing and we don't want them to suffer more. So a lung bath is given to these patients. The preferred energy is usually 6 or 10 MV, and a dose which is being reported in literature varies from 50 to 150 centigrade. Usually an SAD setup with APPA field or an opposed oblique field is preferred, but an extended SST field can also be used if the patient needs to be elevated or if the patient needs to be treated on the gurney. So the dose calculation is being performed on the mid-play, and for the patients who have difficulty being transferred to the treatment couch, they can be treated on their gurney, and the treatment couch, if possible, should be moved out of the way. For those patients, only one single open field is being given, and the MUs will be doubled since we are not giving APPA field. Some of the things that can be used to ease the breathing for these patients is either to use a breastboard or some cushion underneath to elevate them, but ensure that you tilt the gantry in order to make sure that the lung is perpendicular, the gantry is perpendicular to the lung. So here is a DRR image, which is being planned in a planning system, and it shows how a field can be designed. So if you are using a planning system, here are some recommended margins which can be used for PTV. So a lung plus the whole lung contour plus 1.2 cm margin can be given to contour a PTV, and then an 8 mm margin can be given to a treatment field. Usually the diagnostic scans can be used to make these plans ahead of time. Otherwise, if you do not have a diagnostic CT scan, hand calculations can be performed using emergency treatment modules on the machine to quickly perform a hand calc. So the most important factor that comes into play for these COVID patients is the lung consolidation. So we all know that the density of lung is lower for compared to the normal tissue. So we always apply some correction factors to calculate that. But when a patient has inflammation in lung, the density changes. So that can be calculated if we have a diagnostic scan available, or so this is just a picture which is showing the amount of consolidation, and you can see that this varies in different patients. So there have been several studies which have been performed to calculate the lung consolidation. There's one study which is being performed by Yuan et al., and they took a cohort of 12 patients to perform this study. They used a dose of 50 centigrade with an APPA technique. The lung consolidation that they found out within the COVID-19 patients was somewhere between 0 to 0.19. They used a regression plot to plot these patients and derived an empirical formula which can be used to calculate MU per centigrade. Now this formula uses the body thickness of the patient and also the consolidation, which can be calculated using this empirical formula. So this is a regression plot which is being shown here. Different consolidation levels were chosen ranging from 25 to 75%, and you can see that the MUs change as the body thickness increases. The MUs also increase, and similar with the lung consolidation, the MUs increase as and lung consolidation is more. So here is what the clinical trials are proposing for the workflow to be. If there is a diagnostic scan present for the patient, that can be used to evaluate the lung consolidation, patient separation, field size, and MU can be evaluated. Otherwise, the emergency module of the machine can be used to quickly generate a plan like we do for these emergency setups. The next thing would be to get the patient in a clinical setup position, either laying flat if the patient can, or he can be given, some kind of cushion or other device to be elevated for optimal breathing. The next thing would be to perform a pre-treatment verification, because obviously we want to make sure that we are delivering the dose to the right spot. So an onboard imager or an EPID imager can be used to verify the setup position. If MLC needs to be placed, they can be placed, or if they need to be modified, they can be modified on the fly. And then finally, the treatment is delivered. It needs to be made sure that the gantry position is perpendicular to the position of lungs, because that's kind of critical in here. So here are the people I would like to express gratitude to. And also, I want to say that, the physics aspects of these treatments are very simple and straightforward. All we need to follow are the best practices for COVID patients as we do for our cancer patients. Thank you very much.
Thank you, Priyanka. That was really excellent. And I think that we can learn a lot about how to do the same process in our centers as well. And now it is my pleasure to ask my dear friend, Dr. Anil Anand, to make his presentation. We are eager to hear of your experience at Max, sir. Over to Dr. Ekiana.
Yeah, thank you very much. Can I have my slides, please? I think Priyanka is going to show up soon.
I'll be sharing the slides for you.
So before the slides come, now at this moment, we have discussed so far what radiation can do for the acute presentation of moderate to severe COVID pneumonia. And at our hospital, we have not gathered courage to treat those patients so far. But I'm going to share my experience, which may be useful to quite a few of us, in a patient who came with lung cancer and subsequently he developed COVID-19 pneumonia. Next slide, please. So this was a 49-year-old male with adenosquamous carcinoma with solitary brain metastasis, and he presented in September 20. CT scan showed that there was a primary lesion in the lung and there was a single metastasis in left cerebellum. However, before we could embark on his SRS to the left cerebellar lesion in the brain, he developed COVID pneumonia on 14th of October last year. And so we had to abandon this treatment and he went into home isolation. And fortunately, he recovered and came back to us after about 3 weeks on 2nd of November with a negative RT-PCR report. Next slide, please. So when he came, he had cerebellar symptoms and headache. So we gave SRS to the cerebellar region, delivering a dose of 30 grain 5 fraction from 2nd to 7th November last year. So it is about 5-6 months back. 1 week later, he developed fever and unfortunately he developed amoebic liver abscess and he had a lot of pain in the right lower chest, upper abdomen. And the hepatologist treated him with metronidazole, ceftriaxone, and hydroxychloroquine. However, when he was recovering, he developed hemoptysis. And at that point, we did a CT scan of the thorax on 21st November, which showed that, unfortunately, in addition to the primary lung lesion, which was the cause of hemoptysis, he had also a persistent involvement of COVID pneumonia with the CTSS score of 14/25. Next slide, please. So this is the CT scan in axial and sagittal coronal section, and you can see the primary lesion on right side of the lung, the consolidated lesion. And you can see now COVID pneumonia manifestation in bilateral lung in this picture. Next slide, please. So the dilemma was what to do. He was having recurrent hemoptysis, and the dilemma was whether we should treat his primary lung tumor with a palliative dose to control the hemoptysis, and what impact we would have on the presence of a persistent pneumonia. Mind you, it is not same as acute manifestation of the cytokine storm and acute emergency. Here, patient had only mild cough, but the CT scan was having a moderately severe COVID pneumonia lesions persisting even after 5 weeks. Next slide, please. So we had a long discussion amongst ourselves and with the patient family, and we were tossing whether radiation should be delivered. And then we went around and saw that it is low dose radiation therapy, as we described, 0.25 to about 1 gray. This kind of radiation can help in COVID pneumonia. And so even if some dose goes to the lung, will it have adverse effect or would it have a beneficial effect? So our patient had recovered from acute phase and he had persistent COVID pneumonia. And if you see this reference which I have quoted from British Lung Foundation, around 50% of the patients of COVID pneumonia can have these persistent lung lesions up to 3 to 6 months. And what we will see, and many of us would have seen, patients coming to us and we are treating the cancer of any region, including lung, and lung is one of the most common cancer. We would find many of these patients may have COVID pneumonia manifestation and hence the problem. Next slide, please. So after discussing all that, we took a decision that we would deliver a palliative radiation to the lung lesion in view of recurrent hemoptysis, but we will deliver it with a VMAT to minimize dose to the surrounding lung. We try to concentrate our dose to the primary lung tumor and minimize dose to the normal lung. And we delivered a dose of 8 gray in single fraction to the right upper lobe lung lesion, which was the non-small cell lung cancer. Next slide. So this is the now the slide which is showing. On A is the slide which I have shown before. This is the COVID pneumonia plus the right-sided lung cancer. The B part, the middle panel of slide is showing isodose dose distribution. And if you can see, I have mentioned the doses which have gone around the tumor, which was D95 of 8 gray 7.6, which was very circumscribed around the tumor. However, a low dose went into 2 gray, 1 gray, 0.5 gray, 0.25 gray, and 0.13 gray in different parts of the lung, which nearly covered almost the entire lung. And it is known that VMAT can do that. It can have a little higher spillage outside the region of interest. Next slide, please. Sorry, just stick to this slide, please. So the third slide is the response which we saw. So this is 1 week after delivering a single dose of radiation therapy. So you can see that the primary tumor has some little cavitation, but most of the COVID-19 pneumonia lesions have disappeared. So this was a finding which we never expected, and this led to our interest in why this happened. Next slide, please. So the hypothesis was, and we went into literature, and very good, I would say, a write-up by Kirby and McKenzie in Radiotherapy Oncology 2020, was describing that whatever we do as therapeutic radiation, for example, in this patient with the lung cancer, is pro-inflammatory, and we know radiation can cause radiation pneumonitis and all other problems. Today, we are saying we are treating pneumonia, but on the other hand, in many days, we have also discussed radiation causing radiation pneumonitis. So while therapeutic radiation is pro-inflammatory, conversely, a low-dose radiation in the range of say 0.25 to 1 gray is anti-inflammatory, and therefore it is helpful in tackling COVID pneumonia. So in this patient of ours, we could have a therapeutic radiation on the right lung tumor, and the spill which we saw of very low dose of 0.13 to 0.25 to 0.5 to 0.7 to 1 gray took care of COVID pneumonia lesions. So this we are planning to publish, and it's actually under publication. And but at the end, what we want to say is For this kind of situation, we need more studies, and we need also a very careful selection of patients, because some of the patient may have underlying COPD and other problems. So those patients may not be the best to treat. But however, it opens a window of opportunity that if a patient has a lung cancer and COVID pneumonia persisting lesion, these patients with some precaution still can be treated with radiation therapy. Thank you very much.
Thank you very much, Dr. Anand. We conclude the first session and over to Kanika for the next session. Kanika, please take over.
Thank you, Dr. Parekh, for conducting this session so well. And I must thank Dr. D.N. Sharma, Dr. Pitanjali Singh, Dr. Sasi Priya, Dr. Govind Rajan, Dr. James Welch, Dr. A.K. Anand, and Mrs. Priyanka Kapoor for sharing their personal experience of delivering LDRT. So we realize that our chat box is full of questions. There are questions in the Zoom chat box as well as YouTube chat box. So may I now invite our chairperson for the next session, Dr. Vijay Anand Reddy, and also invite Dr. Kanika Sharma to moderate the next session to answer some of the practical questions which have been raised in this session. Over to you, Dr. Reddy and Dr. Kanika. Sir, Dr. Reddy, sir, are you there? I think I cannot spot Dr. Reddy. Go ahead, Kanika, and start, I think. So we had compiled a case, but in the interest of time, we will not take the case, but we will take the case, the questions pertaining to it. Just a moment. Are my slides visible?
No.
Not yet.
Not yet, ma'am.
Just a second. I think I'll share my screen again. So these are few questions which we already had put in, and questions which our audience have said. Can you see it now?
Yes, ma'am. Yes.
We had compiled certain questions, but primarily the questions which all of us are asking is, who is the right patient, whom to give LDRT, when to give LDRT, how to give LDRT, how much to give, and when not to give. And these have been primarily which our audience have also. So I request Dr. D.N. sir, if you can take the first question, that who is the right candidate?
Well, Kanika, can you hear me, Kanika?
Yes, sir.
Okay, thank you very much for giving me the opportunity to be on this panel. Well, it's a difficult question that who is the right patient. Because if you deliver to the sick patient, a very sick patient in ICU kind of thing, then it's not going to work. If you deliver to a settled patient whose like parameters are fine, so it is probably not will be effective. I mean, it's a waste. So in my opinion, the right kind of patients are the ones like whose saturation is going below 92, 91%. That's parameter number one. The second is that if you have a CT scan and CT score is above like 16 or 18, then these are the patients who are likely to benefit from the radiation treatment, and who are likely to deteriorate if you do not intervene at the right time, Another point I would say that if the remdesivir has been already tried and has not worked, then I think then it is right time to switch out to the low-dose radiation treatment, which doesn't have any toxicity at all. We have seen in all the trials, it doesn't have any toxicity now. So it's safe and there's nothing wrong in trying these patients.
So Dr. Sasi Priya, would you want to add any other more criteria which you have incorporated in patient selection?
Yeah, we also experience the same. See, all those who are desaturating and who are worsening day by day, those were the candidates whom we selected, and we got good results. Once we waited for a longer period to elapse, the results were poor.
So I'm not sure whether Dr. Ajay, Dr. Manoj have joined in the. Dr. Manoj, Dr. Ajay, are you around? We wanted to know from our intensivists, because we always are talking of this cytokine storm, and it's like it's coming. So I want to know, how does it come? Can they predict that we are heading for it? Or anybody from the panel, Dr. Sharma, Dr. Welch, can somebody predict the threshold where we should be alarmed?
and we can propose radiation at the right time?
I can provide a partial answer to your question, Dr. Sharma. Although I cannot go into the details about predicting when the cytokine storm will actually strike, I believe that the optimal timing for the radiation, as I said in my presentation, is when the patient presents to the hospital for need of oxygen and hospitalization, but not so advanced that they require ICU management. And this is preferably during the first 10 days, the onset of fever, cough, dyspnea, and additionally, we might suspect that patients who have high CRP or other pro-inflammatory markers and seem to progress on dexamethasone or remdesivir or other treatments, but do not yet require intubation are the optimal patients and optimal timing. Additionally, we believe but don't have evidence to support the concept of treating patients who are either over the age of 50 or over the age of 60 to allay the fears of carcinogenesis down the road.
So that brings me to a question, Dr. Dian. Yours was the study which included patients, the median age was 50 years. Yes. So how did you counsel your patients for the risk of secondary malignancies? Because I think our first principle, do no harm, always strikes us. So how did you counsel, and how many at least were agreeable after understanding the risks of secondary?
Okay. Thank you, Kanika, again for asking this question, because this is a very relevant question. And in fact, let me tell you, many patients did not give the consent for this. So it's a right consent, but I tell you, the patients were deteriorating, and the relatives were quite concerned that the patient is deteriorating, so we'll have to find some treatment rather. These are the patients who agree easily. Rather than patients who are stable, having a score of like maybe 5 or 6 news, but stable. They may not probably agree. I would say the patients who are not who are not improving with the treatment they have been offered, like remdesivir or steroids, and the oxygen which is already going on. Despite all these measures, if they are not improving, they are the easy ones who give the consent. So I would say, I mean, in that sense, I would say that if the cytokine storm has already set in, there will be no point, taking these patients and counseling them. The patients who are likely to go into that storm, where the markers are rising, CT scan is showing the worsening, CT severity score, and the clinical picture is deteriorating despite the measures which the hospital is offering. I mean, that is when they will benefit most, and then they are easy to agree for this kind of treatment.
So, sir, as you must have faced in your center, and most of us, when we bring these talks to our pulmonologist or intensivist, they have the thought that your modality will be when we've exhausted everything. So there is a tendency to say that, okay, once your patients are in ICU, then we will think of it. So who would be those patients who you would say no, that we will not benefit?
Dr. Kanika, you need to show them the historical data, and you need to tell them the facts. I have a paper which I read in that. It was from 1942 with open hair. It is in that study they have clearly divided the patient into 3 groups. Although it's an old study, but let's respect what our seniors have done. They divided the patient 3 groups. One, when they delivered the low dose RT in the first week. The second, when they delivered between 7th to 10th day, and third, when they delivered the radiation after 10th day. And they're the best, 100%. All patients recovered if the radiation was delivered within the first week of the illness. So if you delay, and if you just defer the treatment, then I think so it is not right. If you deliver the treatment, then it is the first week, first 5 days, I would say. In all trials, if you see the all 4 trials which are published, mine is printed. Mine is published as a preprint. It's already under the review, but hopefully you will see in another maybe month or so. But let me tell you, all the trials have shown the benefits within the first 5 days. So if you delay, if you pulmonologist and the intensivist they are adamant, I think you need to counsel them first, and you need to tell them. And you need to show them the data and the evidence, that if you delay, it's not going to help.
Right, thank you. So, Dr. Rastogi, Dr. Vikas will be there. So, there are some, Dr. Vikas, are there some means to know that the lung already has developed fibrosis? Because the picture of COVID is like, you really cannot, as an oncologist, make out between the patch and the fibrosis. But fibrosis, again, appears to be a contraindication. Dr. Rastogi, can you please enlighten us?
Yeah, sure. What we need to see, and we know that ground glass opacity are the commonest finding. However, when the progression to fibrosis occurs, it is earlier seen in the subpleural interstitium, predominantly in the lower lobes. That is where one needs to look for the fibrotic changes. We've also seen that frank consolidations, the denser the consolidations, the more likelihood of the lung healing by fibrosis, especially in the COVID scenario.
So can you just explicitly tell us that are there some pathognomic features of fibrosis where we ourselves can take a call that this would not be a patient we would agree to give RT, like anything pathognomic on the CT scan?
Yes, generally they are conveyed in the report, but you see architecture distortion, bronchiectatic changes or bronchiolactatic changes, and the pleural thickening. So these are indicators of fibrotic changes beginning to occur.
Right, sir. Thank you. So, Dr. Welch, we just wanted to know about the dosage because during the last 2 weeks, we realized there are proponents of dosage of 0.75. There are proponents, Dr. DN insists that we should step up to 1. So, if we were to start a trial in today's date, what should be our dose which we select?
Well, I would probably say somewhere between 0.3 and 1.0. I am not convinced that we need to go to higher doses, and I fear that our colleagues in are going to have challenges with the continued high dose of 1.5. So my recommendation might be as low as 0.3, but as high as 1.0.
So any criteria by virtue of which you decide whom to go for 0.3 and whom to go for 1.0?
That is the subject of the prospective randomized trial. So I don't have any evidence or justification, just my personal hunch, and that's not scientific enough. So that's why we suggest doing the randomized comparison between these two presumably safe and presumably effective doses.
So Dr. DN, would you disagree or?
Well, no, I'm more or less the same, but I based on my experience, I would say it should be between 70 centigrade to 1 gray. I'm telling you because this is based on my experience, based on my trial and the historical data. I still respect the historical data which has been generated. In those trials, the dose was 0.5 gray, but that was by deep low X-ray, X-rays. It was with deep X-ray therapy. And that time there was no concept of the lung correction factor. If applied the lung correction factor, the dose will be something like 0.75 gray. So that's why in fact we use 0.7 gray. The dose has to be decided between the risk of secondary malignancies and the effect of the radiation for the as an anti-inflammatory effect. So I would say it should be between 7 gray to 1 gray. After 1 gray, the risk of secondary malignancy might be a little higher, and it might incite the inflammatory effect after 1 gray. Because ultimately we know the radiation causes inflammation, as Dr. Anand also highlighted. I would settle in if I give the opportunity for doing a phase 3 trial. I would keep it 1 gray because you need some dose to incite some anti-inflammatory effect. So I may be wrong, but I will slightly disagree with Dr. James that dose of 0.3 gray will be too less in today's time. I would say that it's safe to give 0.7 to 1 gray. That's the dose I would settle based on my experience and based on the data which has been generated. Let's not ignore the data which has been generated in 1940s and before 1940s.
So, sir, a few audience have asked that what would be the probability of fibrosis with higher doses?
Can I answer that?
At 1 gray, what would be the probability of fibrosis? That is the audience question.
Okay, can I answer that?
Yes, sir.
Okay. See, let us, just to remind to all the audience that the lung fibrosis is actually a consequence of the pneumonia. So all these patients have the risk of fibrosis, mainly because LDRT, but it will be mainly because of the post-pneumonitic, sequelae. So let's not forget that, Although LDRT can cause fibrosis, but I think less than 1 gray is too less a dose to cause the LDRT, but it's a genuine concern. Only the long-term data will tell that whether it will add on to the lung fibrosis, which is already there with the post-pneumonia sequelae. But in my opinion, I think so, like at 0.5 gray, 0.7 gray, it is probably unlikely to induce any fibrosis, But yes, above 1 gray, it might induce, but I think it's a question which will be told by the time, We are also following our patients, very closely, and we are planning to call them back and do a CT scan if possible to see the amount of fibrosis which they have, But I think it is a concern, but not to, prevent or better the low dose benefit to the patients, to needy patients.
But so our population, as you know, a lot of our patients have post-tubercular sequelae and a lot of other factors. So has anybody analyzed in our particular patients that smokers and patients with sequelae of previous COPDs, are they also having the same amount of benefit?
Let me tell you, Kanika, the many trials, in fact, have the exclusion criteria if they were tuberculosis or they are smoking, So many would not be very encouraged to include these patients for the trial, because it's still in the early phases. We don't have a very firm, confirmed or robust data to arrive at this conclusion. So I would say if the patient already has some these kind of existing lung pathology, low dose may not be the right kind of treatment in this patient, because then it might add to the problems. So I would say not to be trying patients who have tuberculosis, early tuberculosis and scarring and fibrosis earlier.
Yeah, I could read the Provent. I think they have excluded everybody with some drugs which are pneumotoxic, chemotherapy, busulfan, all that have been excluded.
Yes.
I think that would be factored while planning the trial. So
Right.
there are concerns about sanitization, because logistically you are bringing a COVID positive patient into your suite and transferring the patient back. So how to handle the machine? We are not aware of the fumigation or the sanitization procedures for the machine. Any tips for that?
Okay, so the right approach for this would be to dispense the treatment on the weekends, like Friday and Saturday, when you don't have the routine cancer patient for treatment. So your job will be easy, number one. Number two, for sanitation, I think it's just a simple. Just ask your citizen colleagues how do they sanitize, They get the same treatment. It's the same kind of. They also take the patient for like 5-10 minutes. Our treatment also takes about 5 minutes or 10 minutes, So it's the same procedure. It's the same kind of machine. If you find, it's not a different, But it should be one alcohol-based, substance in the beginning, and then like sterilized water and then like dry mopping and all that, It takes about like 40 minutes, but we on the safer side keep a gap of about 3 hours if it is a routine patient. If it's a COVID patient, then we don't mind, because if they both patients are infected, and then we just do the quick cleaning and sanitation, and then we take. Otherwise, I would say you should keep a gap about 3 hours if you're treating a routine patient after a COVID treatment patient. So that's safe. Although there are not many firm guidelines, but we feel that it is adequate. Some even say half an hour is good, and But to be on the safer side, I would say 3 hours should be the gap, which is enough for the routine cancer patient after a COVID infected patient.
Dr. Welch, any other thing you add on for the machine sanitization?
Yes. While I agree with Dr. Sharma that if I had to pick one dose, it would probably be 0.7 to 1.0 gray. But as far as the logistics go, I have a different approach. And rather than wait until Saturday or Sunday, because I feel strongly that there is a window of opportunity and that temporal window can close rapidly, we are prepared to give treatment at any time, any day, but we have the provision that if that happens, we must stop using that linear accelerator that day and transfer the patients to the other LINAC. So we might have alternative backup plans for the other linear accelerator for our cancer patients, but the LINAC that has been used will be terminally cleaned and closed down for the remainder of the afternoon. So that is the approach that we would perhaps use to expedite treatment so that we do not miss the window of opportunity of when this treatment would be most effective.
Dr. Wells, I fully agree with you. I didn't mean that we should not treat on the weekdays. I just said that preferably on the, if you are like beginning the trial, or if you are beginner, then it is
yes.
preferably on the weekends, But in fact, we have treated patient Wednesday afternoon, So I would say if you have to treat a patient weekdays, we prefer the afternoon, so that we can send all the patients home and we can, treat only the COVID patients if there are 1 or 2 patients on the afternoon. So we prefer the afternoon when there are no subsequent patient for treatment. But I agree, yes, anytime if there's a patient to be treated to pass on the benefit, we can offer anytime, even day or night doesn't matter for that.
And then that machine would be closed down for the day for terminal cleaning.
Yes, that's right.
So there's a question that since most of you, at least 3 of you, have conducted the trial in the country, so do we need approval of ARB for the trial, or if you're doing out of trial case, then also ARB approval is required?
No, not at all. You don't need a prior approval of the ARB. You just need an Institute Ethics Committee approval from your local institute. That's good enough because we treat many. COVID is actually benign disease, and you treat hundreds of benign diseases. In fact, we treat many benign diseases in our hospital, So it's just like any other benign disorder. ARB doesn't have to, pitch into this one. But let me just remind you, it is only the patient has to be treated only in a research setting and only in a trial setting. You cannot offer this treatment to a routine patient because we don't have any guidelines from ICMR or ministry or any other agency outside the India, or the WHO. That means you can treat only as a trial patient and do not treat any patient as a routine patient, because then you are going to land up in the medical legal issues, because so far it has not been approved by DCGI or like WHO or any other agency. So restrict your patients population to only the research setting and not outside the trial. So that should be safe.
So there was a question: is Dr. D.N. Sharma planning a phase 3 trial?
Well, I send my manuscript for the publication, and I will request my ethics committee once I get the publication done. Based on that, I will ask for the phase 3. And definitely now with the second wave, it is worth trying. Because the death rate is much more than the initial, and the morbidity is also. In fact, it's taking a longer time. This wave is taking like 12 days, 13 days on average who are sick. As compared to previous wave, it was taking just 3, 4, 5 days. So I would say, well, I'm looking forward, and now we have more data. We have wider now based on the trials done outside and with our trial, and we have in fact overcome the logistic hurdles as well. We are fully geared up, but I'm just waiting for my paper to be published. On the basis that I am going to ask for the randomized control trial approval from the ethics committee. So yes, I look forward, and I need best wishes from everybody. Thank you.
I had a question. Like when I ran through the ethical committee for the same, they gave us a huge list of documentation. So
yes.
EGCI permission letter. So is it center specific, or if one of the trialists has thought
it is actually
used by others?
You are right, Dr. Kanika. In fact, I had a couple of calls from different centers in India. They also got the same kind of question that the local committee told that ethics committee. The local ethics told them to take the DCI approval. In my opinion, I don't think we should take the DCI. We should DCI approval is required. If the ethics committee feels, then that's a different scenario. It's the final call has to be taken by local ethics committee. If they feel that DCI approval needs to be taken, then of course there is no option. But I think so they can be convinced that this type of treatment, now we have 4 or 5 trials published, and it's not that kind of a new or a fear treatment anymore. So with that, I think so we can convince the ethics committee and institution committee, especially the administration authorities, that yes, we do not need a DCI approval. It's already treatment which is in the domain, which is in the circle, and it can be imparted. In fact, now some people are even eager to pass on this to routine patients. I got a call like from one of the hospitals. They said we have a sick patient, and we want to treat this patient by low dose radiation. So can we go ahead? I of course feel that without the ethics committee or a trial, you cannot go ahead. But I think so. DCI approval is not required. I would say it's probably an extra hurdle, unnecessary hurdle.
Dr. Govindraj wants to add. I think he has something.
Regarding the handling of both cancer patients and the COVID patients, what we are doing is we are treating them daily. In the morning session, we treat the cancer patients, and between 4 to 7, we treat the COVID patients. And after that, we follow the disinfection protocol, because I believe that it is unethical to make the patients wait for the weekend, because we know the earlier we intervene, they perform better. So that is why we are giving it daily. And as far as the disinfection protocol is concerned, to the people who are aspiring to take up this trial, it is very easy, because we got the disinfection protocol from the service engineer of the machine concerned. So they have given a beautiful table which all part has to be disinfected with what all chemicals. So that is very clear. So we got all those chemicals. We trained we have outsourced an agent who does the disinfection in the night. So after our last patient goes in the night at around 7 o'clock, this disinfection team comes and they disinfect, and we leave it dry for overnight. And the next day morning, the cancer patients start. This is how we are doing, and we are quite comfortable with that.
So there's a question, sir, and this was something I think Dr. Welch would remember me also asking him, that we are in an era with bevacizumab, torcezumab, remdesivir. So where does LDRT stand, and what is the interaction we can expect out of them? Because with so many things in your kitty, where do you put it in the landscape? One, I could get remdesivir failure. Where else do you pitch in LDRT, and what is the interaction? That is a question by Dr. Ashu Abhishek. Dr. Welch, the interaction of
Sure. I can take a first stab at answering the question. Perhaps in the United States, dexamethasone has become a very popular first choice, and it is a good anti-inflammatory with a long track record, but some patients may progress on it. If there is any indication of clinical deterioration on dexamethasone, remdesivir, or other standard treatments, that might be the opportunity to pull the trigger, so to speak, and use the LDIR approach, in my opinion. That would be the right time. We do know that dexamethasone is anti-inflammatory, but works through different mechanisms and perhaps less protein mechanisms compared to radiation.
So I think we've partially answered these two questions. Any laboratory and radiological criteria, sir? Any specific you have been using apart from the inflammatory markers, or intensivist order, the CRP, TROPI, IL-6, ferritin, LDH? Any other marker you have added on?
No, in an ideal world, we would have all of the cytokines that are imaginable, but in the practical setting, we are restricted to some of the more commonly used ones that are affordable and available.
So anybody has started doing a CD count to see the effect of LDRT, any conversion of CD count? That was a proposal by our hematologist that you should analyze CD count. Any value in adding that to the trial?
I'm not convinced that there would be a strong justification for that or what to predict, but if there is a sound logical basis for it that I am not aware of course I would support it, but I'm just not aware of the rationale, and we are not doing it routinely.
So then somebody's asked for special precautions for the staff. I think all of us, Dr. Sasipriya, I think you can take that. What additional measures did you take for your staff who were treating these patients?
We are giving PP kit to all the staffs and all technical staffs and non-technical staffs everywhere. That is from security, from security to clean tech, and all radiation technologists and radiation oncologists. Everyone wear PP kit. That is the only precaution we are taking.
Anybody has allocation, segregation, that these are the patients, staff who had recovered, and they would be safer? Any segregation of that sort? Sometimes people propose those things that, okay, the people who have already come out of it, they would be safer to treat your patients. Anybody following such segregation based on own recovery?
At one time, we were trying to do that so that we would be working in shifts, chronological shifts, so that not all of the therapists would be in the department at the same time. And in that way, if we did have a catastrophic exposure, we would not have to dismiss everybody from work for a quarantine period. So that was our initial effort, but for practical reasons, with the volume of cancer patients we have, we had to be a little bit more practical as far as that. And instead of chronological shifts, we're more physically segregating our staff from each other to avoid such contamination.
Right. So somebody has also asked about the cost. I believe for the trial, I believe we cannot ascribe any cost, but any of the panelists could take that question. What could be the approximate charge for one fraction?
Well, I guess, can I answer this question?
Yes,
well,
sir.
For the time being, we are taking only patients in the research, so I think it should be free. We should not charge anything from these patients because the ethics committee will not allow that to be charged on patients, but if you are doing routine, like maybe after some time, if it gets established, like just one fraction charge of the routine patient, what we are treating for other cancers, the same, it shouldn't be different, one. But let me, Kanika, can I add just 1 or 2 points, regarding the safety of, this personnel and the staff areas. It's important because if somebody, trying to do a trial, then these are important, See, what we used to that we sent our RTTs and the physicists to our COVID management team for training, And then after that, before starting trial, we did SCTC dummy runs, I mean, just took one, volunteer and, thinking that he's a patient, so how do we transport and how do we treat, and how to, guide, So these are some of the things which we can think of, Additionally, we are trying to design a box. My colleague, Dr. Haresh, is in fact designing a box, cloth box, having the facility for oxygen, IV fluids, and everything. We are trying to design with the help of the IT. It's a research project. So maybe hopefully, if we have that, then I think that will be very good. For safety measures because the staff caregivers will be, will be at comfort. That it's genuine concern from their point of view because they are not the clinicians or they are not the physicians. So I think that will be good for the safety.
So Dr. Matthew was likely to join us, but we had some confusion of the timelines. His son was graduating today, so he had to leave. So this question was for him. And I think a lot of people were asking Dr. Pitanjali also in the chat box. So Dr. Welch and Dr. D, and both of you can answer. Do we need a cutting-edge technology to deliver LDRT, or should we go with our basic 2D or 3D planning?
Well, my answer is big no. You don't need 3D CRT or IMRT or VMAT for this kind of treatment. It's just 1 gray. I mean, it's less than 1 gray. People are using like 0.5 gray or 0.7 gray. Well, it's a wastage of time and efforts. And on the top of that, if you're doing a CT scan, you're exposing your CT scan staff and your own staff for the the virus unnecessary exposure. Because let me remind you, even if one RTT staff gets exposed and gets positive, you will be demoralized. Entire team will be demoralized. So I will not recommend any CT-based treatment. It's a simple treatment. If you can't give 1 gray by your simple radiation treatment, then I think it's not. I mean, it's unnecessary. In fact, this question shouldn't come up also. I am against it. I mean, maybe people can take me wrong, but doing an IMRT or VMAT or 3D CRT for a dose like 1 gray, I think it's unnecessary. It's just like splitting the hair.
So, any questions from this particular audience who have joined us?
Dr. James has a point,
Yes.
I could follow up. I agree with Dr. Sharma that it is not necessary, but if it is available and can be done efficiently, meaning in less than 15 minutes, I would not turn it away. So Dr. Matthew Katz has said that at his facility, they are able to use the diagnostic CT scan that has already been obtained, and within 20 minutes, they can generate an IMRT plan. And if that is the case, and the treatment can be done efficiently, I have no reason to say no thank you, because it will, for public relations purposes, PR purposes, I can say that I'm doing the best I can to reduce the heart dose, the spinal cord dose, the scattered radiation that causes carcinogenesis. Even though I'm not sure, I truly believe it in my heart. I agree with Dr. Sharma that it's not necessary, but I would not turn it away if I can do it efficiently and it's available.
Thank you, sir.
There was a question about concerns of cardiotoxicity, because many of these patients are cardiac compromised, and we know even a gray of radiation can be detrimental. So any concerns as of now, because one of the studies was documenting the dose to heart as well. So should we be trying to constrain heart if we are doing cutting?
No, I would say no.
I think it would be stretching it too far, even I believe that. So I just wanted to read out what Dr. Matthews has texted to us, because his inputs are really, very nice. So I think that could just give us a summary also of a lot of things, and then we can take any last question. Dr. Vinita can just track if somebody's having a burning question. So as he did send his slides, he summarized that there are some key features which you should know. The opioid prevent protocol is an excellent phase 2 trial, but it is yet to be refined and adjusted. The VA trial is similar. So he says that he has been screening new inpatients for COVID in his hospital, and he's been seeing a range of clinical courses. He feels that high inflammatory markers, that is CRP, and progressive course that respond only partly to dexamethasone and remdesivir, then they continue to progress, are the best we can help out. This is what he feels. And treating patients beyond 10 days, he feels it would be a challenge. It is treating within the 10 days of appearance of fever, cough, and dyspnea, which would be better. For the age, he says, since the younger are more likely to recover and they have higher risk of cancer, second malignancy, so he suggests a cutoff of 60 years as a workable initial trial settings. Although he does say there are centers using 50 plus, the Lowell is taking 65 or 60 plus for diabetes, COPD, and major health issues. So as of now, he feels 60 plus would be the right time to do it. Then he also says that a prior chest CT, as already mentioned by Dr. Welch, most of us do have HRCTs in hand for diagnostic, can be utilized for a quick field design, and one can use the old data for retreatment, and he would stick to a lower dose like 50 centigrade based on certain criteria, and I think that is what he sums up with. So Dr. Vinita, any burning more questions? And I would expect you to wind it up for us now.
I think wonderful, very stimulating discussion that we had today. I understand that not all questions are answered, but at least we have found some way into where we stand in terms of LDRT today. Can I ask one question to Dr. Welch? Dr. Welch, in India, now we've begun to see a lot of mucormycosis and fungal infection, and we are attributing it to the rampant and frequent use of steroids. Are you also facing a similar problem?
Fortunately, no, I'm not observing that right now, but I guess my eyes will be opened and more on the lookout. But I would provide a commentary that if that is the case, maybe that is further justification for looking at the radiation option instead of the steroid option.
Another question was, is there any use of hyperbaric oxygen for treating radiation in, COVID-19 induced lung fibrosis?
I have no experience or knowledge of that application myself.
Because we are seeing a lot of patients who are having a long-term oxygen requirement, even when they've turned COVID-19 negative, which is a big trouble right now. You know, even after they have turned negative, their oxygen requirement because of the lung damage is quite high.
There might be some justification based on the fibrosis that we see after radiotherapy. I just don't have any knowledge or clinical experience directly with it, but it seems to make sense as long as the patient is out of the acute and subacute phase.
So I think
which we had here, panel discussion was similar. Despite the patient turning out negative and the CRP falling down, the oxygen requirement just went on going up. And yesterday she just got ventilated. She was on a ventilator yesterday. So we still are not clear on a lot of things, the correlation of the markers vis-a-vis the oxygen requirement and the viral burden. So I think a long journey ahead.
Yeah, nausea will last for weeks and months sometimes, and I have patients that still cannot smell or taste properly nearly a year later.
So I think with this, we wind up this session. We had a wonderful attendance today, a very stimulating discussion, very good insights shared by all the speakers. Especially, I would like to thank Dr. D.N. Sharma, Dr. Pitanjali Singh, Dr. Sasi Priya, and Dr. Govind Rajan, Dr. James Welch. Thank you, sir. And I'm sorry you had to wake up early in the morning to catch up in this session. And thank you, Kanika, and thank you all the panelists, and thank you all the audience. And at the end, it is my duty to thank Oncology Forum and especially Mrs. Nidhi Mittal for providing us this platform to conduct this session. And hopefully we will have an end to COVID-19 infection and we'll find a way out. Thank you so much, everyone.
Thank you, ma'am, for such a enlightening session on this. It was a very interesting webinar. Thank you for conducting this, ma'am.
Thank you.
Thanks. Bye-bye.
Bye. Thank you.